Well, good morning and good afternoon, ladies and gentlemen, and thank you so very much for taking time out of your busy day to join us on our call, How Do We Heal the Healthcare Value Chain? A closer look at healthcare providers. Today, all lines are on mute, but we're very interested in the questions that you have, so please place those down in the lower right-hand corner of the screen where you see it says Q&A. Type those questions and make sure you send them to all panelists. During today's event, if you have any technical questions, please reach out to me in that same area as well. Now, this event is being recorded, and without further ado, it's my extreme privilege to turn the call over to your host and moderator today, Constance Carroll. Constance, the call is yours.
Thank you so much, Jeff. Welcome to How Do We Heal the Healthcare Value Chain webinar by Supply Chain Insights. I am so happy to be your host for today. Before we get started, I just wanted to go over a few details. Today's agenda includes Laura Ciceri, founder and CEO of Supply Chain Insights, leading the presentation, sharing results from the same titled Supply Chain Insights research report. And throughout the presentation, Laura will ask our special guest panelists, Roddy Martin, Managing Director, Value Chain and Operations with Accenture, and Karen Conway, Executive Director, Industry Relations at GHX, for their insights on the healthcare value chain. We also want to hear from you, so please participate and ask questions in the Q&A section. We will compile them as we go, and we will get to as many possible toward the end of the presentation. Today's Twitter hashtag is SCI Webinar, so please go ahead and tweet out nuggets of information in the social networks. So let's get started. Laura, I pass the baton to you.
Awesome. So it gives me great pleasure to be here today with Roddy and Karen to share the results of some recent research that we've been doing. This is one of a couple of series of actual presentations that we've been doing on this research. We started with our first webinar where we talked about the overall state of the healthcare value chain, where we see that the parties within the healthcare value chain are really at very different levels. If we look at average percent changes on value chain financial metrics, we can see that the hospitals are growing operating margin on average. Days of inventory are actually being reduced at the hospital level, and they're able to see revenue per employee increases. But if we look at medical device companies, we see that the operating margins are improving. They have made no improvement in days of inventory. They have made some improvement in revenue per employee. But the pharmaceutical companies are facing a cliff right now where operating margin is declining. We still have not seen an improvement in days of inventory. In fact, we see it going up, but they have made a lot of improvement in revenue per employee, primarily because of the fact it's a much more supply-centric focus of those value chain partners. So as we look at healing the healthcare value chain and we look at the changes in the cash-to-cash cycle of how are we dealing with payables, which is in blue, how are we dealing with days of inventory, which is in purple, and the days of receivables, we can actually see that the hospitals are becoming much more attractive in terms of terms with their suppliers, but we're not seeing the translation into a measurable cash-to-cash variation. In fact, what we see is that the cash-to-cash is actually going up for suppliers. So let me call on my two experts here. You know, Roddy, as we think about the hospital value chain or the healthcare value chain, and you look at these ratios and you think about it, what's your view on the state of the value chain and the parties and their maturity?
Yeah, Laura, I think it's very interesting if you look at the three players, right? Obviously, hospitals at the point where service is delivered, and then you've got two different kinds of suppliers, namely the medical device side and the pharma side. And you can actually see that the pressure has really been on hospitals to improve their operational capabilities. And I think that's why you've seen a burning platform that's driven so much improvement in their capabilities. The medical device manufacturers have always been quite good at supply chain. They are much more supply chain aware than I think pharmaceuticals have traditionally been. And I think in pharma, you know, they're still protected by bigger margins, but it's very clear that the pressure is on them, and I think that many of these acquisitions that have happened over the years where the integration hasn't necessarily taken place, I think that integration, that the consolidation has happened. You've seen the revenue per employee go up. I think the risk of managing inventory is still not sort of sunk in, and so they're still tending to manage risk as high levels of inventory. But it's clear that as you move further and further away from the patient, you've seen sort of less of a burning platform to drive real operational excellence in supply chain.
Karen, your thought here, if just looking at overall financial metrics of the parties, what are your thoughts?
Well, you know, it's interesting. If we look at the period of time, the one thing that I have seen on a very positive side is that hospitals and healthcare systems are becoming better at doing business. Literally, it was only about, 10, 15 years ago when there were people who were running the business, and there were people who were there to take care of people, and they didn't talk to one another and they didn't trust one another. Now they understand being a good business operation is critical to having the resources to take care of people. The other thing I'm seeing is if you look at inventory, and that increase in inventory, while it went down on the hospital side, it increased on the supplier side. One of the other trends we've seen since about 2000 is that hospitals, as they started feeling cost pressure, started asking their suppliers to manage their inventory, but not necessarily in some of the best ways that we've seen in consumer packaged goods, for example. So particularly around things, the most expensive, highest technology products, things like hips and knees and cardiac stents. So many of those are now managed on consignment, or what is called trunk stock, literally in the trunk of the supplier representative, and brought into the hospital. The problem is there is no consistency. There is so much variation, and that is actually increasing costs on the supplier side. And because healthcare is a system, we all are paying for it. So that's an area I think in the medical device area we have to focus on more.
No, I couldn't agree more. But, as we look at the evolution of value networks and trading partners working together, that goes through steps. Roddy, we've seen this in the consumer packaged goods. And, we can bring data to the door of the suppliers, but we've got to use it. And we can't just use it inside out. We've got to use it outside in. And one of the questions I have as I've gone through this research that, Roddy, I'm going to come back and ask you is, at what point in time do we have that burning platform for pharmaceutical companies to start to design outside in and not just look at supply chain as a function focused on sourcing, but really starting to look at it as a system and the redesign of supply chains as a value system? Any thoughts here, or do you want me to come back to you later on?
No, I think there is a really good learning from the consumer goods industry and in fact even to an extent consumer electronics, and I think that's why you're seeing quite a few supply chain leaders, ex-CPG, pop up in the pharmaceutical ranks. I think in consumer goods, value was defined as the product in the consumer's hands, and that value proposition and the cost to serve has been an evolving model in consumer goods against which they're driving. I don't think we have a good understanding of the segmentation and the cost to serve in its fullest extent in pharmaceuticals. So as we get a better handle on visibility, on common standards, on better sharing of information, I think those costs to serve will be more evident and allow the value proposition to be formulated and visible right at the point at which value is delivered to a patient in a hospital and then made visible to the suppliers.
But, Roddy, if we think about consumer packaged goods, we had Walmart, which was a large player forcing a real change in the value definition with consumer packaged goods companies. And, of course, we had Procter & Gamble and the leadership of Outside In with their consumer value network in top-to-top meetings. Here we've got hospitals that are very regional players dealing with very large global suppliers. And many of these global suppliers have defined supply chain as a function, very focused on sourcing. Where do you think that leadership comes from?
Well, I think, as you correctly put it, I think Walmart drove the change, the thought-leading change, and also the operational changes in the consumer goods sector. But I think there is enough pressure on healthcare as a system for us all to realize that ultimately it is all about the patient. So it's not necessarily just about the at Walmart, it's about patient and the effectiveness of the healthcare system. That's becoming more visible. Now, one of the things that you did see in the leading consumer goods companies is that they formed joint value creation teams. So these were internal functions inside of a manufacturing organization that worked together with the supply chain and the merchandising operation functions in the retailers. I think that's the next step that has to happen in hospitals. So to see joint value teams from suppliers work with value teams inside of hospitals against the same definition of value and starting to share information. Now, I know that sounds like a kumbaya statement, but 15 years ago we were saying the same things about consumer goods, and look where they've got to today.
I agree, and that was the purpose of the study, was to look at where are we on the definition of value. And we did a study and we're very excited about it. We actually had 68 hospital providers respond in the study, and I was excited to see how the hospital supply chain had evolved. Roddy, we've worked with these companies for many years, but 75% of hospitals today have a formal supply chain organization. And when we look at the ability to really look at, the organization, it's becoming broader than I had actually realized, and it includes now 82% of the companies that we surveyed a value analysis role reporting through the supply chain organization, and the leadership of these groups has increased in the organization. 53% now report to the chief financial officer, or 20% report to a vice president. So we're starting to get the evolution of leadership in the hospital to a much higher degree than I had believed before I did the survey. And we also are starting to see that we have the aggregation of buying, so that while the hospital is a small entity, we're starting to see aggregate buying. So in this study, I was actually very encouraged by the maturation of the hospital supply chain. Karen, your thoughts? Were you surprised?
I was actually not surprised. I was very, very pleased. There has been rapid movement. I think, again, 10, 12 years ago, you very rarely had a supply chain organization. You had what was called materials management, and we laughed a bit and say, yeah, it was usually in the basement next to the
sure
morgue.
did. Yeah.
And now we have a situation where you're actually seeing, in some cases, chief supply chain officers, so people having a much more strategic, higher level role. The fact that they're also reporting into the chief financial officer, in the past, it was more about, the CFO saying, can you reduce the total supply cost for the adjusted patient day? And now with healthcare reform and the way that hospitals will be reimbursed, which is not on volume, but rather on the value that they can deliver, value being a function of cost and quality, the CFO is going to be looking for the supply chain organization to be delivering work at a much more strategic level that fit to the overall corporate objectives.
And I just find that so exciting. Roddy, how about your thoughts?
Yeah, I do too, and I think, Cal, as I was listening to you, I think that the point is that where you're actually delivering value to a patient, the mental model can very clearly see that it's a system that delivers value to a patient and it's dependent on suppliers. But I think because the value proposition in a big system way has not necessarily been well defined by every single pharma company, there's certainly some leaders out there that have done that. I think they're still grappling with that end-to-end versus a functional view. It's still about moving product, and I think that there is still, the age-old issue of high margins that don't necessarily mean that there's a massively burning platform. I think there's a lot of competition. But I think the key point I want to make, and that is, I think the mental model of supply chain has formulated quicker in the hospital at which the patient service is delivered than it has done in the suppliers to hospital services. It's coming, but it's not quite there yet.
I think that's so true. And what do you think will drive it in the supplier's mind? When do we have that compelling platform?
Well, I think there's some very interesting regulations that have just come down the road that relate to, the FDA actually now putting their foot down about supply chain performance. So if you as a supplier can see that you're going to have a stock out of a critical product and you don't warn the FDA that it's going to happen, if you do that enough times, they're going to shut you down. So I think that both from a regulatory control point of view, from a visibility of the healthcare system point of view, from pure focus on bringing down costs in the end-to-end healthcare system, I think there are enough lights shining on this issue to actually drive that change in supplier performance.
I do too. And one of the things, Karen, that I found very, very interesting in the survey that we did was that we now have a much higher level of value creation where people are looking at what drives value. And 35% said it was lowering costs without reducing quality care. And they're looking at value definitions much more systemically and doing this value analysis. 72% have a value analysis team. And we're also starting to really look at, how do we manage value and what are the factors? And what I found interesting was that on average, people will consider 7 of 9 of these factors. But Karen, right at the top is total supply chain cost. Where do you think we are on the definition of value and the transformation from cost to value and value-based outcomes? Your thoughts here?
Well, first of all, I think that people are starting, it's definitely an evolution. We have a long way to go, but I think a lot of the new payment methodologies that are rewarding value-based purchasing, for example, is going to require this rethinking, this mindset that Roddy was speaking about, because it really is going to be measured. 70% is based on these core measures that unfortunately have not quite been well defined enough, but they are a factor of cost and quality and efficiency. 30% of value-based purchasing, which determines your reimbursement, is also based on patient satisfaction. So that's a whole nother issue. And it's interesting, I'm starting to see suppliers look at things differently and say, how can I deliver value to the customer? And so say instead of something as non-medical as I sell the TV that goes in a patient room, I heard the supplier the other day say, you know what, I'm not in the business of selling TVs, I'm in the patient satisfaction business. You're seeing things like infection rates, because hospitals are not going to be paid for hospital-acquired infections anymore. So they need to understand what's the role of different products that are being used in terms of reducing infection rates or readmissions. The key is look at that next line under total cost of procedures. We've had a lot of press recently about the prices that hospitals charge. The sad thing is that many hospitals can't actually tell you how much it costs them. And that gets down to some very basics related to, are we capturing data about the products being used, the type of protocols at the point of care in a way that can be shared across systems so we can really understand value from all of its different facets.
And, it looks like that's such an opportunity for us, Roddy, as we look at value chain programs and we look at what's driving value and the redefinition for us to be able to look at, how are we doing this? you know, it looks like the traditional focus of negotiating lower prices versus some of the more holistic of standardizing products and improving product utilization and working with trading partners, it's looking like we've got a shift from pure sourcing to being able to look more holistically at trading partner relationships and to be able to look at how we trade off these elements of not just looking at lower prices, but being able to look more holistically. Your thoughts here?
You know, Laura, I hate to jump on the bandwagon of big data, but I think that there is one fundamental technology evolution, call it analytics, call it whatever you want to, that I think is going to provide the real enabler for us to look from the outside in. And I think this may be what the healthcare supply chain system is really looking for, where we have, you know, tons of data, but the ability to, without standardizing and integrating and all the stuff that we've had to do over the many years, to actually look for patterns and define questions, and then define questions and look for answers, because that's what real outside in takes. I mean, it's not just a question of responding to a customer, to a patient need. It's about understanding what's actually happening in the patient front, and then being able to reduce complexity of the end-to-end system and adapt the suppliers to match to that strategy. So I think what we could eventually see is that the hospitals putting a lot of pressure, and we've seen in some cases this actually starting to happen, putting a lot of pressure on suppliers to be part of you know, replenishment schemes and tracking schemes, and exactly the point that that was made earlier about consignment programs. And I think that pressure could come from the hospitals. That's the point at which value is delivered. It's the point at which value is measured. And I think ultimately, as we get more big data visibility, see more patterns, I think we're going to see where the real blockages are in their healthcare system.
I think you're so right. But when you think about big data, Roddy, and you think about the V's of big data, the volume, the velocity of data, and the variety of data, which of these do you think are the most important in that transition? Is it just the volume of data, or is it the variety of data with unstructured data like patient records and outcomes, and the combination of data like images, or is it the velocity of data, you know, sensors and Internet of Things? Which of those do you think is going to cause the most impact, or do you think it's going to be all three?
I think it's I think it is all three, but I would definitely say it's the variety. I mean, this is not just big data, right? This is not just about terabytes. This is way more than terabytes of data. This is petabytes plus. And I think it's about the patterns. So of course volume and of course the velocity, but the variety is what's going to give us the insights. And I think the analytics, looking at that variety, looking for the questions and then finding the answers to those questions, and then of course the organization and the process to translate those insights into action, because I mean just having those insights from big data without translating them into the end-to-end system is not going to change anything. But I do think that, you know, more and more hospitals looking at the variety of data on a smaller scale, perhaps even more regional scale, will start delivering insights to the suppliers that I think may shock them ultimately. I mean, we've already seen Pfizer very publicly state how they're going to take the supply chain to the control tower and the cloud. They've gone public with that. It's all about big data. I've seen a number of other pharmaceutical manufacturers start their initiatives on big data. I think over the next couple of years, we're going to see it have a huge impact. But to answer your question, I think it's about variety, and I think it's about the analytics to find the insights and then the capability to translate those.
Yeah, and I don't think it's about supply chain done like it was in the last decade. I think it requires different techniques. What do you think, Karen? You know, as you think about Roddy's comments about big data and doing things differently, your thoughts?
Yeah, he's absolutely right. You know, it's interesting, but as I said, I keep going back to we have to get the basics right. There is I get a little frustrated because I think there's been such a focus on electronic medical records, which I think are foundational to change. But we need to look at that from, we start with you know, we start with capturing that data and having that data for that individual patient. But then we need to feed that kind of data into registries where we can start looking at what kind of protocols, what kinds of procedures, what kind of products are leading to better overall population health. That requires some standardization of how we're collecting data around the world so we can have that robust information. And then what's interesting, and then make that a system that feeds data back into the medical device manufacturers, the pharmaceutical manufacturers. I focus a lot on medical devices. What are the clinical attributes? It's not whether brand A or brand B is better, but what are the clinical attributes of products with particular protocols that are serving patients with particular diseases, for example, and then allow that to go back into R&D. So we're truly making the kinds of products that are starting to deliver value. And without that kind of data, the accuracy, the standardization, and the feedback system, those are all the keys that we need to achieve these overall goals.
And Karen, you know, that really is the redesign of the value chain to be able to collaborate across trading partners to improve value and also to work across functional silos within the hospital. And if I look at this current state, you know, it looks like we have moved from a focus on sourcing to, you know, really starting that journey. And, you know, if I think, Roddy, around what happened in parallel industries, for example, and, you know, CPG, right? You know, you and I go way back here. How do we get the right stuff? You know, how would you advise healthcare providers to start working on those trading partner relationships and doing it differently? This is a slide that, you know, I stole from Procter & Gamble as they talked about their efficient consumer response programs in Europe, where they talked about that until they had shared vision, skills, incentives, resources, plan, and leadership aligned, that they really had a lot of false starts. With the data that you see here, and knowing hospitals have made a lot of progress, but we have the suppliers really struggling to move from inside out to outside in programs, how do we bring the leadership and the shared vision here? What are your thoughts?
Well, first of all, I think that we can definitely take a leaf out of the consumer goods manufacturers. And you know, let me go back to your bricks matter, right? Let's get the basics right. What did the leaders really do when they realized that actually they had to flip their operating model to outside in? They formed joint value creation teams with customers. So, you know, we never saw CPFR really working, but today we're in a much better place to see the real impact of collaborative planning, forecasting, and replenishment working. Why? Because the supply chain team, the sales team, the account management team, and the actual customer, the hospital, and to an extent the patient representatives got together and jointly defined value. So I think that step one, there has to be a joint value creation team formed inside of the supply organization, because otherwise there will continue to be a focus on functional excellence of silos from an inside-out point of view. The second point of view is to start changing the metrics as to how the organization perceives its performing. So what did we see with P&G? Procter & Gamble defined 2 moments of truth, and they said, moment of truth number 1, in-stock availability on the shelf, right? We're going to work against stockouts, and moment of truth number 2, we understand why consumers choose our product. That happened at the leadership level. So let's take that into pharmaceuticals and medical devices and the suppliers and say, let's redefine our moments of truth. I mean, the moment of truth is actually patient outcome. So if we build these joint value creation teams that are cross-functional in the organization, we reach out to collaborate and actively work with the hospitals and the healthcare system, and then start changing some of those metrics to really reflect outside-in performance and the performance that the healthcare system is looking for, and that is at the point of the patient. And then we start driving change in the organization, and I think that's exactly where the leaders in the consumer goods space were. They followed that, they translated, and many of them are seeing those benefits today.
I think that's really an essential point here. And Karen, as you talk about the changes in the payment systems, right? We've got hospitals that are fragmented, they're regional players, they've evolved a lot in their supply chain capabilities. Do you think those changes in value-based outcomes as it's defined in compliance and how we pay and reimburse clients will drive this compelling reason to collaborate and get the right stuff, or what are your thoughts?
Absolutely. It's absolutely imperative. And the good thing is, even though it's a little undefined and people are a little confused and it changes significantly, it just changes the paradigm, there are several things that are really driving this. First of all, as you said, the different payment methodologies, they are really requiring this kind of accountable care, these accountable care organizations. It's not so much what the organization looks like, but how do you bring different groups together that don't necessarily, on the provider side, are even part of the same legal entity or even the same type of organization. You've got physicians' offices, you've got healthcare systems, you've got healthcare payers working together, but they need to be accountable. They have shared incentives and also shared risk for particular patient populations. Okay. Also, the other thing is that reimbursement is going down overall. But to keep the doors open, you need to understand what will help you get better reimbursements. And these are all tied to, again, that patient quality, patient cost, and patient experience. So healthcare providers are searching for those ways that they can maximize value for the patient. In the meantime, the suppliers are having active discussions about how do I drive better value for my customers. The problem is when a supplier is thinking about that just within their own organization as opposed to having those conversations with their customers that an organization like P&G is absolutely superb at. They start thinking of things, well, I'll create this tool or that tool and I'll take it to my customer and say, when you work with me, use this tool. Well, tell me, a nurse is not going to use a different system depending on which supplier that they're working with. So when you bring those parties together and they start looking at how do we create value together for the patient, as we've described, with cost and quality and satisfaction, they can start revising how they do work together as well as their products, and it all focuses on operational excellence in an environment with lower reimbursements, with things like the medical device tax. We're not going to see the top-line growth necessarily. We've got to focus on that operational excellence and bottom-line health. All of those things are driving to what we have seen as success in the example that Roddy was talking about with P&G.
And what I find really exciting about this industry is, number one, it just matters so much, right? But number two is, with these changes in compliance and the evolution of hospital supply chain acumen, I'm really hoping that we can drive the suppliers to not just think about supply chain as a function, but to really build the leadership to build that end-to-end process to start to think outside in and to start to do what Procter & Gamble did around those joint value creation and to build supply chain teams over their sales and go-to-market efforts. And Roddy, when I talk to hospitals, many of them are frustrated that the suppliers have not really done that. And any thoughts there? Do you see anybody really starting to make that change, or any advice you would have?
Yeah, I mean, I think that there is definitely change. I mean, from many of the clients that I'm working with now and even what we saw back in the days of AMR and Gartner, and that is supply chain is definitely getting more visibility inside of the supply ranks. I mean, it's always been the case in the sort of more medical device-orientated companies, but certainly in the pharmaceutical space. So I think that's point number one. This evolution is happening. But let's go back to the Walmart, P&G, Colgate, Kimberly-Clark example. What did Walmart? They drove interaction at a top-to-top level. They forced the discussion with very senior executives from supply organizations, and they defined what their desired outcome was in Walmart. And I think that's what needs to happen. Unfortunately, the hospitals don't necessarily have the power base that a Walmart has. So, it's the old question, where's the Walmart of the hospital industry? But I think those top-to-top discussions and a few leaders who are going to break out of the hospital side, and this has already happened, have those top-to-top discussions, start the collaboration, start reflecting on the results, because the results will be there if the processes are followed. And I think this industry will catch up quickly. I mean, I think that the one fortunate element of where the suppliers are in this whole cycle of cross-industry supply chain development is that we've learned from consumer electronics, consumer goods, even the big industrial suppliers. So it's not like we have to forge something that's brand spanking new. Let's pick up the learnings that are applicable. Let's reflect on those learnings. Let's get a few leaders to start using those learnings as best practices and start reflecting on the outcomes, and you watch, they'll follow.
Well, and Roddy, one of the things that we're doing at Supply Chain Insights that I find really exciting is we're trying to look at the elements of the value chain of healthcare and trying to look at which metrics matter to build market capitalization on financial markets. And, you know, I think that's one element, you know, that people are not clear on, is which metrics matter as we build these value networks. And one of the things that we're actually going to be talking about in next week's webinar that we're doing is the value chain metrics. And as we look at medical care, which is the hospital provider, and we look at medical distributors, and we look at major pharmaceutical companies, one of the things that we're seeing in the correlation of the financial ratios is that the ratios that matter are very different by entity in the supply chain, but they correlate very highly. So if we look at the combination and medical, we're able to get a correlation of 0.73, and in medical distribution 0.84, and major pharma 0.78, which are fairly high R-squared values. But the differences in the metrics that matter to the balance sheet to drive market capitalization are stark differences, with complexity growing as we go from the supplier through the value proposition. And one of the things I'm hoping that this work could help is for people to be able to step back and say, how do we redesign for value, and which financial metrics matter, and sensitivity to the fact that Altman Z, which is a measurement of risk, really matters in pharmaceutical, and maybe the design of attribute-based systems outside in could help major pharmaceutical companies to mitigate that risk. But if we look at the medical care industry and SG&A, the cost of goods sold, and how we make that easier with suppliers working on easier to do business with, or the redesign of these trading partner relationships, it's my hope that some of this can help. What are your thoughts here around the metrics that matter?
I agree with you, and I think that, you know, the suppliers have their value equations from a business point of view defined. In other words, their financial performance metrics are fairly well defined. But I think what needs to be balanced with that is the definition of value in the healthcare system translated back to suppliers. And I think that's what we, that's the whole essence of joint value creation. I mean, if we're going to jointly create value between patients, between hospitals, and between suppliers, we have to define what that value is. I think it's pretty obvious, but I think we have to find a way of quantifying that. And then we have to find a way of bringing that into the financial value propositions of suppliers, and find a way of driving service metrics in their equations that reflect on that healthcare system. And I mean, it's not an easy task, because they do have, you know, privileged margins. They do invest an incredible amount of money and resources in research, and time to market is not trivial, and all the risks they have to deal with in supply chain in comparison to other industries. But I think it does boil down to the translation of value at the point at which it really counts, which is the patient, and the reflection of that value down the end-to-end supply value stream all the way back to the suppliers, and then incorporating that into their financial metrics as a key component. I don't know where that's going to come out. I don't know how long it's going to take us to get there. I think it's going to take a couple of years, But I do think that some companies are on that journey as they consolidate and look at the future.
Yeah, and one of the things that I find, if I just look at this chart and I look at the highlighted or the bold elements, there are ones that go across, right? And so if we could focus on a balanced approach on the ones that matter across the trading partners, one of the things that I find, and I think back to CPFR, which we made so many mistakes in terms of use of data and holding people accountable, but we never really tied it to balance sheet metrics. If I look here, I think there's an opportunity for us to align in a balanced way around the metrics that matter. So I find this kind of exciting. It's my hope that it helps.
Yeah, I think it really is. Sorry to interrupt you, Laura. I think it's really interesting, and I think that the expression that you and I used to use as analysts talking to manufacturers and leaders as they build their supply chain capabilities is, what are the balanced trade-offs that you need to decide that you make? And those are going to be for different products, for different types of medical suppliers. But I do think that when you look end-to-end, when you've defined the value proposition, when the holistic value proposition of the healthcare system is translated into the financial performance metrics of the suppliers, then the leaders can start looking at what are the balanced trade-offs that we need to make, and what visibility do we need, what analytics do we need to be able to make those balanced trade-offs and maintain our profitability and growth without losing margin.
And I think, one of the mistakes that many companies made in the defining of trading partner relationships was looking at singular metrics like inventory without looking at the portfolio of metrics and looking at balance and raising the potential. So I think that one of the things we've got to do to heal the healthcare value chain is align on the metrics that matter. The second thing I think we've got to do is really think about process automation in a very different way. And, I was talking to GE Healthcare the other day that's working on the Internet of Things and the automation of hospital beds. And, I know, Roddy, we've been talking about RFID and the automation of kitting for surgical units. But, Karen, one of the things that you actually talked to me about the other day, which I think is very exciting work at GHX, is the automation of implantable devices and building enterprise systems of record. I was wondering if you could take the group through what you're doing there and why.
Sure, absolutely. And this is one of those areas where we are seeing tremendous value through collaboration. This is something we started researching probably 4 or 5 years ago, and we did this in conjunction with the community of providers and suppliers that are working with us. First of all, we identified that in the implantable device supply chain, which is still highly manual, disjointed, duplicative, there are so many different players involved, and they are not part of the same organization. You have the surgeon, who is often independent. You have the hospital, you have the vendor representative, you have the nurse. And we began mapping out the different steps related to, say in an OR, say we're doing a hip replacement, and what are the various processes and how can we reduce cycle times, as well as how can we improve visibility of key information across the supply chain. So you can see it's broken down into case scheduling. That's usually happening, first of all, with the doctor, the surgeon, and the patient. And then they're notifying and booking time within the hospital, and they're notifying the representative that we're going to be doing a hip, you need to be bringing in these particular products. Then they're starting to prepare the different materials. Then you actually have the procedure, and then oftentimes the PO is cut after there is a reconciliation of what was actually used. The nurse is in there actually documenting this, usually very manually, at the same time that the vendor representative is. She or he, the nurse, is doing it for the implant log, for charge capture, for what they are expecting to be billed, the salesperson for replenishment, and also to keep a record so they know what to put on the PO and what to charge. Oftentimes, because they're doing it manually, surprise, their information doesn't always match. And then we actually did some work very early on just trying to automate the process, being more accurate in capturing these products where you have to be getting the lot and the serial number, and how do you put that into an EDI transaction where that kind of information has not been required, plus you have to deal with the privacy laws. We started with those blue boxes down at the bottom, and amazingly, without even an application of new technology, just by process improvement and best practices agreed upon by the industry, a significant reduction in that time from when a procedure happens to when the supplier gets paid. Now we're working more in terms of that demand visibility that you see in the case scheduling, because literally sometimes the representative doesn't know what needs to be brought in, or the hospital hasn't been advised what kind of procedure it is until a couple of days before, even though in most procedures you're talking at least a couple of weeks in advance. And by doing these best practices, by sharing data across systems, by frankly just talking and communicating sooner in a more standardized fashion, you can see we took what was about 15 steps and really have been able to take it down to 4. And that's where the real value comes. In so many different areas, you were talking about trade-offs. There is value related to cycle times. There's value related to inventory reduction. There's value in reduced DSOs. And it just changes the nature of the relationship. And in the end, you have better patient care because you have better accuracy related to what kind of products, again, are being used in the application of patient care and what's driving better value in terms of lower costs through efficiency, through lower inventory, and we also have visibility into what's driving better quality care.
So, Roddy, we've talked about integration of data, and unfortunately, when we just bring data to the doorstep of the trading partner and we don't really build inter-enterprise systems of record or rethink the processes outside in, we can't use data, right? And one of the things that I find very interesting, and this is an example by GHX, but I find the evolution of different kinds of solutions that are inter-enterprise, answering the question that I think the enterprise applications can't do in terms of how we automate these outside-in processes. Are you seeing things out there that you find to be interesting as well?
Yeah, and I think there, to a limited extent in the supplier base in the healthcare industry, but certainly in the consumer electronics, the industrial electronics and consumer goods are starting to go down there. The answer is, there's a step change in technology. I mean, if you look at products like, for example, MarkLogic and Hadoop, a lot of this control tower technology and the ability to analyze structured and unstructured data. I think the problem is that our paradigm in data management and data sharing has always been based on a relational model. And I think in building architectures for relational data, we need to know what questions we're trying to answer, what metrics we're trying to derive. And I think that's very constraining, whereas in the big data environment, looking at these new analytics capabilities in an unstructured and a structured world, I think we can actually look for the questions, let alone look for the answers. So I think that's happening. I think it is early days. I think there's a lot of, smoke and mirrors in discussion. But, I mean, there are really companies out there, certainly in the consumer electronics industrial side, who are looking at their supply side. So, in other words, manufacturers looking at really critical supply chains of suppliers with critical elements for helicopters and all sorts of industrial components where, you don't ship the major item unless it's 100% complete, and there are hundreds and thousands of small items in a bill of materials. And so therefore being able to look way outside the boundaries of the organization at structured and unstructured data and look for, identify risks before they're going to occur. That's already happened, and we're already seeing some of those consumer electronics companies do things like that. I think that's got to translate into consumer goods. I don't think we're very far from it. I'm currently engaged with some consumer goods companies who are starting to think along those lines, and they're starting to organize for it. So it's one thing to be experimenting with these new technologies in the labs within the IT organization. But when you see an organization starting to put transformation teams, starting to reorganize around digitization, then you realize this is for real, and this is going to make a very big difference to the way the mental model and the operating of supply model of a company operates.
So, you know, I kind of closed with, we did the survey. We were very blessed to get great participation from the hospitals. We still have the survey in the field to understand the supplier response and how we design for value. But I'm very encouraged to see the growth and maturity of supply chain teams within hospitals and the alignment around the new payee systems and to really look at patient satisfaction. I think there's still a leadership opportunity to build cross-functional teams and to work better with trading partners. And as I think about it, and I think about this redesign for value and think about outside in and the use of different data types and the use of different systems, I think that it isn't the traditional processes or the traditional technologies. I think it requires real leadership to start to think about outside in and management of those end-to-end processes. And it's just my hope that supply chain leaders everywhere step up, because I really believe it's so key to answering this problem. And Karen, I thank you for joining us today. What are your crisp thoughts here for leaders in terms of how they heal the healthcare value chain? Your thoughts?
Well, I think it really does have to start with, it starts with the patient and what drives value. I think you're going to have a strong focus, as we said before, in terms of reimbursement and how we're going to get paid. This is unlike, we can learn from other industries, but this is not about we want to be selling more health care. We want people to be well. That's what delivers value for the patient. But everybody needs to operate a business and keep those doors open. So we need to be looking at, this broadly, from the raw materials all the way through to when those final products are used, get that feedback loop, start talking to one another. We need a lot of innovation. Steve Jobs once said innovation is all about having enough dots to connect. In healthcare, we need to understand what the dots are, who's got the dots, and we need to share information about the dots. And that has to start. This is new for healthcare. Start talking to everyone.
And I think we've got to really start talking around those value-based outcomes and have that, kind of burning value proposition. But, Roddy, as we think about the movement from efficient sickness of transactions and check-in, check-out, and, the more traditional view to this focus on health and wellness, what's your advice for leaders? What do you think we need to do to really drive that value alignment?
I loved the perspective of define the value proposition of the patient, and that because of the state that hospitals are in and their critical role in patient care, the burning platform has been with them, and that's why we've seen the change. So therefore, let's translate that back. Let's do what the consumer goods companies did as they talked about shelf-backed design. Let's talk about patient-backed design. I think step one in the supplier base, the leaders have to change the mental model of what a supply chain really is. It's an end-to-end system to support that value proposition in the hospitals. And it's not just a collection of functions that are integrated and making trade-offs against each other. And I think changing that mental model and getting the business to operate in an end-to-end way in their business operating strategy, that will drive the change. It's young days, and transformation is early because these supply chain leaders are feeling their way up to the senior ranks in these organizations, but it's definitely starting to happen.
Well, thank you so much, Roddy and Karen. This is going to conclude our webinar today. We are providing monthly webinars to help supply chain leaders. Next week, we'll produce our supply chain index work, part 2. Last month we actually talked about the supply chain index, which is a formulaic representation of how the supply chain ratios correlate to market capitalization. We're looking at 36 Morningstar sectors. The last conference we had, a webinar, we introduced consumer packaged goods, retail, food manufacturers, and chemical. This index coming up will actually be talking about the pieces of the healthcare value chain and contrasting them to the consumer products value chain to look at what drives value and market capitalization for each of the Morningstar sectors. That's actually a countdown to our global summit. And then in June we have a session on sales and operations planning. We're currently pulling this study out of the field. We have over 90 responses, and we'll start to correlate the maturity of the S&OP models to what we see in the maturity and formulas and ratios in the supply chain index. And then we continue the countdown on June 27th as we go to another Morningstar group of apparel, food, and beverage, and we give a more intensive look there. And then July 11th is all about big data. This is a survey we just put in the field, and is it a big data opportunity or is it a big data problem, and what are people doing about it? And of course talent, which we believe is the missing link of the supply chain. So for those of us who've joined this webinar today, we'd love to have you join future webinars. It's our goal at Supply Chain Insights to allow our research to be a dialogue with supply chain leaders like Roddy and Karen. And again, thank you guys so much for joining us on our webinar series today. And this will be recorded and available on our website, and we hope it helps healthcare value chain leaders everywhere. Thank you very much and have a great day.